Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenters are Dr. John Dearborn and Dr. Alexander Saw. Dr. Dearborn and Dr. Saw are orthopedic surgeons practicing at Washington Hospital. They serve as co-medical directors for the Institute for Joint Restoration and Research, located on the Washington Hospital campus. In 1999, Dr. Dearborn partnered with Washington Hospital Healthcare System to create the Center for Joint Replacement, a comprehensive, multifaceted program that now serves arthritis patients from all over the world. Dr. Dearborn and Dr. Saw have been in practice together since 2008 and are highly regarded for their specialty in joint replacement surgery. Dr. Dearborn completed his bachelor's degree in biological sciences at Stanford University, also his internship and residency at the University of California, San Francisco. Dr. Dearborn completed his fellowship in total joint replacement at Massachusetts General Hospital in Boston. Dr. Saw is a native of Fremont and was born at Washington Hospital. Dr. Saw completed his bachelor's degree at Haverford College in Pennsylvania. He completed his internship at Massachusetts General Hospital and his residency at Harvard Combined Orthopedic Residency in Boston. Dr. Saw completed his fellowship in minimally invasive and revision hip and knee replacement at Rush University Medical Center in Chicago.
So to start with, who are we? I'm speaking as both myself professionally and from the hospital. We are the Institute for Joint Restoration and Research at Washington Hospital, and that entity, the Research and Restoration Institute, is a partnership between the Dearborn Saw Institute for Joint Restoration, which is our company, and we provide all of the professional services to the hospital for everything that's done under the auspices of the Institute. And then Washington Hospital obviously is the other partner, and they provide administrative as well as support systems, which include nursing and physical therapy and everything you need to run a joint replacement program. We have a mission statement which our core team drafted back in 1999, which is to provide state-of-the-art joint replacement care in a highly efficient yet personal manner. And that's, as I said, a 14-year-old mission statement, but it is still what drives us today, even as we are much busier than we were back in the very, very beginning. So how do we carry out that mission statement? How do we deliver this type of care in an efficient and personal way? The first is paying attention to what's happening with research currently in the literature, making sure we're staying absolutely cutting edge in everything we're doing from a surgical standpoint, from a nursing care standpoint, from a rehabilitation standpoint. So we think being current is very, very important if we're going to be delivering state-of-the-art care. The second is not being afraid to be innovative with regards to techniques and the implants we're using. Obviously, if we're doing innovative things in the operating room and on the joint replacement unit postoperatively, we need to be doing the research to back up that and to show that, in fact, it's better than what the standard is. So the current research and the technique and implant innovation that we do here, those work hand in hand. And then the third area is what I like to call continuous process improvement. whereby we're auditing how things are going in real time. We have lots of meetings, we look at our data, we look at our outcomes, so we constantly can tweak things to make outcomes better for patients in the future. So what are we? Well, we start with the expert clinicians, which includes not just the surgeons, but also the nursing staff and the rehabilitation staff. And so when I say expert, I'm saying that this is all that your physicians, your nurses, and your therapists do. We're not doing all areas of medicine. We're not doing all areas of orthopedics. We're only doing joint replacement work. So you have a narrow focus, but then also, at least from the surgical standpoint, we have special training, fellowship training in joint replacement and revision surgery. So we are committed to doing just this and doing it very, very well. And our nursing staff is also committed. They don't work elsewhere in the hospital. They're working exclusively with joint replacement patients. Our physical therapists work exclusively on the joint replacement unit, developing and perfecting techniques for rehabilitation patients who've had hip and knee replacement surgery. In addition to being what we would consider expert clinicians, we have a very integrated care delivery system, and I'll build that out a little bit. But that's very different than what you see in other hospitals this size and even larger hospitals. When we're talking about integration, I'm talking about all the different service lines that can affect care, communicating and working together and problem solving together, and we'll build that out a little bit. We're also separate from the regular hospital, and I tell people that we quarantine our patients. Our unit where we take care of our patients, where we see our patients, is separate from the hospital, so you're not walking through the same place where sick people are coming. Veterinary offices and pediatrician offices have figured this out a long time ago. You have your well child entrance and your sick child entrance. Well, hospitals haven't done that. Except for this one. So we have a quarantined place where we take care of all of our elective surgery, which we think is very important. So building out a little bit on the expert clinicians piece, we do have a very narrow focus, as I mentioned. We're doing exclusively joint replacement surgery. So from the standpoint of the surgeon, what that does, when we give up doing shoulder surgery and give up doing foot surgery and fracture work, et cetera, we can focus on perfecting the surgical technique for doing hip and for knee replacement as well. So it's very important to do large volumes of cases where you're doing the same thing consistently. That way, if you make a change in your technique, you can quickly see the effect of that change because you've done 8 or 9 of them that day, and if you make a little minor change, you quickly see, okay, is this an improvement or not? Very important to have that narrow focus. The second thing is from a nursing standpoint. Your nurses here are also expert clinicians, and by taking care of joint replacement patients day in and day out, those nurses are able to very finely tune their protocols for managing patients after surgery. They can figure out which medications work better than others and work with us and communicate with us on developing protocols that are driven from different types of medications, staying again current on new things that come out. When you're trying to take care of all different types of orthopedics, you really can't stay current in any one field. It's just too broad these days. So the nurses are as focused as the surgeons are. And then from the standpoint of physical therapy and occupational therapy, same thing. The process for rehabilitating joint replacement patients is in flux. Length of stays are getting shorter, so our joint replacement patients have to be doing better than they used to be by day 1, day 2, day 3 to be able to make it out of the hospital. If patients stayed in the hospital a week after a joint replacement, which is what they did when I was training 20 years ago, there's just no way in the United States we could deliver joint replacement care because Medicare is upside down financially right now. We need to be finding ways to do things efficiently, effectively, obviously not increasing complication rates, but doing things less expensively, but delivering the same or better level of care. And in order to do that, to save money and do it better, it takes this integrated care approach where you're really super specialized, and that's what we're doing here. So between the surgeon, the nurses, the therapists, perfecting their part of this, you get overall clinician expertise. So when I talk about clinician expertise, I'm not talking about the surgeon and how, gee, I'm a great surgeon, or Dr. Saw is an even better surgeon than me, or any of that. It's not we're not working in a vacuum. It's all the pieces of the puzzle, equally important. So we talked about clinical expertise, and we talked about the importance of care coordination. So in the middle, of course, you have the patient. And around the patient, you have a surgeon, you have an anesthesiologist, you have nurses, and you have physical therapists and occupational therapists doing rehabilitation. These people are not separate, of course. They're connected. They're connected to the patient. They're connected directly to the patient. And when you consider it, they really need to be connected to each other as well. And from the nursing standpoint, it's not just the inpatient nursing, which is what I'm referring to here, but we have nurses working in the pre-op area, we have nurses working in the recovery room, we have nurses working on the joint replacement unit, and so the nursing area is more complicated than just, okay, here's your nurse for the day. If your nurse in the recovery room is not communicating with the nurse on the joint replacement unit where you're headed, then we've got a problem. So the care really needs to be coordinated, and the surgeons need to communicate with anesthesia. The surgeons need to communicate with the physical therapists. So those connections are very, very important, and those don't happen in every place. The physical therapists need to be communicating with the nursing. And you might think, well, that'd be a natural thing. They're all working on the same unit. They would talk to each other. Well, I've worked in lots of places where they don't communicate, and where nursing doesn't know what the rehab plan is for the patient, and the therapists don't know, what pain medication the patient just received. So that level of communication where you have nurses talking to the therapist, and the therapist talking to us, and us all talking to each other, very, very important. So that's what I'm talking about in terms of care coordination. And the anesthesiologists are equally important in communicating with the nurses, especially with our protocol of using epidural anesthesia on a pretty regular basis. So those anesthesiologists are not just working in the operating room, they're coming to the unit and making rounds the next day, going back and forth with the nurses, making sure that everything that they've done is working the way they want it. So the surgeons are communicating with everybody, the anesthesiologists are communicating with everybody, and that's the important piece of care coordination. And I already sort of suggested the importance of connecting all the areas of nursing, from the pre-op nurse talking to the recovery room nurse, from the pre-op nurses talking to the nurses who are going to be taking care of the patients on the unit, so that those nurses know what to expect, so that that nurse receiving the patient knows that that patient before surgery talked about coronary artery disease or talked about lung disease, so that if that patient's having an issue post-operatively, that nurse already knows that that's a potential problem, and so they're not getting blindsided with patient problems after surgery. And those recovery room nurses also, as I said earlier, handing off to the nurses on the unit. So your recovery room, your post-op nursing unit needing to communicate. And then you might not think about post-discharge, but patients need nursing care after they leave the hospital sometimes. And so that's another important handoff between the hospital side and the post-discharge side. And I've done this little cartoon here for the nursing side, but this is true for the rehab side too. Physical therapy starts in the hospital, but it actually needs to start before surgery. So our physical therapists are talking with patients before surgery at our pre-op education class, figuring out what people's rehabilitation needs are going to be specific for them, and then carrying out those protocols while they're in their hospital, and then handing off to a therapist who's coming to the patient's house after discharge. And you might think, geez, that should happen. Well, that doesn't happen everywhere, and part of our integrated process here has been working on trying to get that to work. It's especially challenging in a place like this where 80% of our patients are not from this area. They're coming past several hospitals to come here to get their care, which means that post-discharge, we're coordinating with nursing units up and down the coast of California. We're coordinating with physical therapy, home physical therapy facilities up and down the coast of California, and then outpatient physical therapy facilities up and down the coast. So it's a huge undertaking, and you can imagine if we didn't have some way of integrating it, it would just be a complete flail. So anyway, this is what we're about, integrating care. So in order to actually have this work, to have the care integration happen, first requires extreme amount of communication. And we're talking not just from doctor to doctor, because of course we're talking about integrating what doctors do and what nurses do and what therapists do. And so you've got to basically get rid of that hierarchy that you might expect, where the doctor thinks he's up here and the nurse expects to be down here. Everybody's on the same plane, and we're all talking about our specific roles and doing that with mutual respect. So that is absolutely critical. The second is we have to have regular multidisciplinary meetings. So we sit in a room all together, the heads of the nursing department, the therapy department, the physicians, anesthesia, hashing out how each piece of the puzzle is working and what we can do to make those pieces work better. So you have to have meetings. And then technology tools like an electronic medical record system that we have here at Washington Hospital, smartphones and things like that that allow us to communicate when we're not actually in the hospital, and to do that effectively. Those help a great deal in terms of integrating care. So what's the result of an integrated approach? Because that's really what we're talking about. We're trying to figure out how to do patient care better. And of course, if you integrate your care, you're going to have an excellent patient care approach. And that's what we've seen here. We see better attention to detail when everybody is involved, because you'll have more eyes, different eyes, looking at the same problem. An anesthesiologist may look at a patient, one of our patients who has hip arthritis, and they may look at the fact that they've also got spine disease in a way that's different than the way we would look at it. Or a nurse is going to approach a particular patient problem maybe different, and their way will be complementary to the way that I might look at it or the way an anesthesiologist might look at it. So with multiple eyes looking at the same problem, we're going to have better attention to detail. And as a result, we're going to have fewer missed details. Patients coming into the hospital with subtle comorbidities, subtle other medical problems, which you can imagine during a hospitalization with surgery might go awry. And if we know about those and people are looking at those from multiple angles, we're less likely to have a problem with one of those issues heading south. And obviously, as a result of that, we're going to be able to contain complications if they happen, and we're going to be able to keep our outliers safe. And we'll talk a little bit about what outliers are. An outlier, it's really a statistical term. Everything out on the bell-shaped curve that's not sort of in the middle area, everything that's out here, that's an outlier. And we look at outliers as complications waiting to happen. And outliers can take many forms. It could be a patient who has medical comorbidities that are really marginally managed before surgery. So a patient who's got a high BMI, so they're carrying way too much extra weight, or a patient who has diabetes that's not well controlled, or patients who have underlying cardiac disease or lung disease. And so any of these comorbidities, as we call them, any of these medical problems that patients may bring to the hospital to have their elective surgery, any of those could affect early and even later outcomes of the operation. So, medical comorbidities can lead to a patient being an outlier, meaning that they're not going to be on our bell-shaped curve. Patients that are socially disconnected, so patients who live alone, or they're estranged from their spouse or their partner, where they don't have connections, those patients do not do as well with surgery, whether it's elective surgery or whether it's a hip fracture. It's very, very important to recognize what the social connections are for our patients, and so we think that's extremely important. Our patients who don't understand what they're getting themselves into, they don't necessarily, it's not just the surgery, but maybe the postoperative rehabilitation, what's going to be asked of them. If they don't understand those things, those patients will not do as well, and they will function as an outlier. And those outliers are much more likely to have complications after surgery. The last one I put on here is patients who have trouble tolerating different pain medications. So if you're someone who can't take narcotics because they make you sick, or maybe you're coming in with a chronic pain condition where you're already on narcotics in a large dose, and so your sensitivity to narcotics is going to be altered. That is going to make you potentially an outlier when it comes to having an operation that most people would do fine recovering from, and you might have a more difficult time. So those outliers, very important. So let's talk a little bit about complications. And what I define a complication is something that goes wrong that doesn't normally go wrong. So that's a pretty broad area. What can go wrong with surgeries? Well, of course, the surgical side can have complications. You can have issues in orthopedics from fixation between the implant and the bone. The bones can crack. The implant can come loose. You can have injuries during surgery to nerves that are around where we're working, injuries to blood vessels around where we're working. Certainly infections can always happen with surgery. Fortunately, they're not very common. But those are generally the classes of things that can go wrong in the operating room. We talked about medical complications that could come from existing medical problems. That's another common thing that we'll see go wrong. A lot of complications will come from the comorbidity that the patient came in the hospital with. So that diabetes that was a little bit marginal in control, the diabetes runs out of control soon after surgery, the patient ends up with an infection. That's a common scenario that we see. So it could be an existing medical issue, or it could be a new one that we weren't aware of that becomes evident while the patients are in the hospital. Who tends to have complications? We mentioned that there are some complications that everybody is prone to, like infections or bones having problems, et cetera, et cetera. But then I mentioned earlier the outliers, the patients who have things that are more unusual are definitely more prone to complications. The patients who aren't an outlier, who are sort of, who are at normal risk, those patients can do well with surgery in just about any joint replacement program. They can sail through without issues. But if you want to run a program that is minimizing complications, it's really chasing the outliers that's the key. So complications can occur early after surgery. While patients are still in the hospital, they can be delayed, in the first couple weeks, or they can occur late, beyond 6 or 12 weeks from surgery. And so we need to be chasing those at every point. And if you can answer the how complications occur, boy, that would be, you'd win the Nobel Prize if you could figure that one out. So obviously our approach here is to avoid complications. I've been sort of beating that one. And the way we avoid complications is to stratify our patients in terms of risk. There are patients who are low risk that I mentioned earlier who are going to do fine in just about any system, and that's the majority of our patients. Probably 80 to 90%. They're at average risk. You can streamline the process for them. You can run those nursing protocols that I was referring to and physical therapy protocols, and you don't have to tweak them particularly. Those patients can just roll through, and they're going to do fine, and they're going to feel like they're well cared for. But there are the outliers that are more at risk, and it's important to identify them before surgery. And if you're going to run an integrated program, that's the key. Identify those at risk before the surgery and make that outlier a non-outlier by stabilizing medical issues before surgery, encouraging the patient to establish social connections that they weren't having before, talking to them about family members that might be able to come and help after surgery, friends, people that they might go to church with, whatever, rallying the troops to help. And I commonly tell patients, don't be afraid to let somebody help you. Many patients don't want to have somebody help them. They feel bad about that. I tell them, let people have the opportunity to bless you because it will bless them in return. So, so the social side is very, very important. And then if we feel like if we can educate our patients before surgery, kind of like what you guys are getting, then they will know what the potential problems are, they will know where the landmines are, and probably fewer of them will be stepped on as a result. Prevention is the ultimate answer to complications. Obviously when they occur we want to contain them and reduce the severity of them, but most complications are actually preventable. If you can stratify the patients and then look out for them, get the ones that would have been outliers to not be outliers, then most of the time you can avoid them. So let me spend just a little bit talking about our program specifically, and then we'll bring up Dr. Saw. There are entities out there that actually look at complications from various hospitals, and actually HealthGrades is a pretty good one. Has anybody ever been on HealthGrades' website? Anybody out there? A few of you. So HealthGrades rates hospitals all over the country, and you can look up I think there's about 3,000 hospitals in their database now, and you can look up a particular surgical procedure at a particular hospital and find out what their complication rate is. And you might say, wow, where does that information come from? Well, it turns out that Medicare patients, all of that data is publicly accessible. And there are companies that harvest that data for Medicare patients, and obviously if a hospital is doing well in terms of complication rates compared to the other hospitals around, they're happy to post that. But Healthgrades posts it for everybody. So if you want to know about where to have eye surgery, you can go and look at all the places that do eye surgery and figure out which place has the lowest complication rate. If you want, you can do the same thing for cardiac surgery. You can do the same thing for hip replacement, knee replacement, hip fracture, etc. And they cover multiple different surgical procedures. So Healthgrades we think is worthwhile. Of course, I'm saying that because Healthgrades likes us. Our program has received their highest rating for hip replacement, which is 5 stars, also for knee replacement 5 stars, and we've had that rating since 2002, which is when Healthgrades started posting. And then they take their programs that have their highest rating, their 5-star rating, and they actually rank them so that there are ones that are better than others. They all have 5 stars, but the ones that are better than others. And in 2011, we were called the safest place in California to have a joint replacement. So that was 2011. So think about all the hospitals that are in California, and here we are, Washington Hospital, with the lowest complication rate, readmission rate, infection rate in California, which is phenomenal. And I don't know if you saw a couple months ago when Consumer Reports came out, they had a large spread in the magazine, I think it was the July issue, looking at safe surgery, and they really dug into it in a lot of different ways in the issue, so I'd encourage you to go out and find it. It's also available online, so if you go to Consumer Reports and you go to their website, you can search for it and you can find it. So they looked at the ratings of nearly 2,500 hospitals in the United States, and they were using Medicare data. They went to another company that grabs this data, and they extracted a bunch of interesting information from it. The first thing that they did is they looked at 5 common surgical procedures, and they posted in the magazine the top 5 in the U.S. and the worst 5 in the U.S. for each of those 5 surgical procedures. And of course, one of those was total hip replacement. And so this is their rating, their hip replacement rating. This is their top rating, and here's the top 5 in the United States, and they're in alphabetical order. So we're at the bottom of that list of 5. So Washington Hospital, one of the top 5 in the U.S. for hip replacement. Unfortunately, Mass General Hospital, where I did my fellowship, is one of the worst 5. And Dr. Saw did his residency training in Boston as well, which is a big surprise. Hospital for Special Surgery, Thomas Jefferson. These are world-class academic centers listed as the worst in the United States for hip replacement surgery. And that reflects readmissions, complications, infections. And it goes back to the concept of, okay, do you have expert clinicians there? Maybe some of the professors, but you got residents doing the surgery. Do you have expert nurses? Do you have integrated care delivery? Well, you got residents rotating on a service for a few months, and then they leave and they're gone. You bring in somebody else. And so what you don't have in those systems, and I spent time, as I said, at Mass General, Stanford, I was at UCSF for 9 years, you definitely don't have an integrated system in an academic center like that. And although the professors, I would argue, are expert clinicians, they are removed from the actual care process. And also in the issue, they took hospitals in each state and they ranked them for surgery safety in general. So not just in orthopedics or joint replacement, but they looked at surgical safety overall, and then they listed them state by state. So you can go to any state, so you go to where your grandkids live and see where their best hospitals are. So the top here is this is of course Consumer Reports' highest rating, and there we are, alphabetical order again. So we get the highest rating in the state. There's Stanford, getting the empty circle, and UCSF with the empty circle. Here's St. Rose, half black, not so good. Good Sam, one of the lowest rated hospitals in the state. Seton also, one of the lowest rated hospitals in the state for surgical safety. Go figure, but there it is in Consumer Reports, and it's all Medicare data. So I encourage you to check it out. So you've gotten a sense that integrated growth gives you safer surgery, integrated approach to patient care gives you safer surgery. As a result, patients see it, they talk about it, and for our program, that's resulted in tremendous growth of our program, which has been by word of mouth from other patients who we've taken care of, by recommendations from the primary care physicians of those patients. So a patient from 100 miles away comes here, their doctor doesn't know who we are, they get a good result from their operation, they go back to their hometown, and they tell them, wow, there's this amazing thing happening in Fremont, and next thing you know, that doctor's sending us all the patients who need joint replacements. Obviously, we're talking about patients being attracted from outside the normal drawing area of the hospital. So that's what's happened here, and we looked at our patient demographics a few years ago. This blue is the Tri-City area. That's the small piece of the pie of the patients that we take care of here. You can see a larger piece of the pie. Here's the peninsula. So patients driving across the bay away from Stanford to have their joint replacement done here. So it's pretty exciting. As a result, you can see our hip replacement volume as a program has gone up. So here's 1999, and here's 2013. Obviously, we're not done with the year yet, so that's why this bar is lower than 2012. So our hip replacement volume has soared. Our knee replacement volume has soared. This is from, again, 99 to 2013, incomplete year. But you can see we're headed up as a result of the growth from having good outcomes because of an integrated care delivery system and clinicians, surgeons, nurses, therapists who only do joint replacement. So as a result of that expertise, we get better and better at what we do. So we've talked about the volume, and what does volume do? It continues to improve our efficiency, and it improves our relationships between our facility and outpatient physical therapy programs or home care therapy programs. If we're operating on 3 people a week from the Monterey Peninsula, then we can get to know the home care agency down there and drive quality. We can say, hey, you know, we're taking care of these patients. If you want our patients from your area to go to you, you need to do what we want you to do. And so we can drive things a lot more with the volume. Obviously, it helps us a lot with cost containment. Volume really helps a lot with that. We can get our implants less expensively if we're buying more of them. That's just one example. And we can accumulate a tremendous amount of data by taking care of a lot of patients, which, as I mentioned earlier, allows auditing of our process in real time. And drives our clinical research program, which Dr. Saw will talk about. We have a massive database of all the cases that we've done here at Washington Hospital, and so we can extract data from that, and we do on a regular basis to fuel research studies that we're doing. And our data has been presented all over the country and internationally, so it's pretty exciting. So with that, I think I'll turn it over to my partner Alex Saw, and he'll talk about specifically hip arthritis and how we treat it here, and what we're doing from a research standpoint.
Today I'm going to try to cover these topics: hip basics, just tell you a little bit about the anatomy, talk about arthritis and what can cause pain in the hip joint, then we'll talk about hip replacement, just the fundamentals, and then minimally invasive hip replacement. We'll talk about some of the techniques we're doing here and some of the other things that you may see in advertisements or at other institutions. I'll talk about a little bit of the controversies of joint-bearing surfaces in hip replacement, and lastly I'll touch on the research that we're doing at our institute that Dr. Dearborn introduced you to. So first, for hip basics, just a basic understanding of where the hip joint is. If you look here in the skeleton, the hip joint's actually in the groin. It's a little bit lower than some people think. It's below the belt line. So if the belt line is up here, the hip joints really live in the crease of the leg and the trunk. And the hip is a ball and socket joint. So on this anatomic drawing, you can see that here is the thigh bone, and this is that ball. It's called the head of the femur, and then it lives in this cup of the pelvis. And so this ball and socket joint gives you many degrees of motion. The blue that you see here is the cartilage, and the cartilage is what allows that joint, or any joint in your body, to move freely and without pain. So you can see here the general structure of the hip joint. This is another cartoon, and again the white shows you the cartilage of the hip joint. And here in this video you can see that the hip, not unlike your shoulder, has many degrees of motion. It has flexion, extension, it rotates, it goes in, it goes out. It's a very diverse joint, but because of that it has to have a lot of cartilage covering a lot of areas. So you can imagine with this kind of motion that there's many potential ways for that hip to wear down or for arthritis to set in. So what is cartilage? Well, you probably see it almost every day. Cartilage is that white stuff on the end of a chicken bone. That's, again, in every joint in your body, and that's what lets that joint move freely and without pain. It's the covering on the ends of the bone. And so when we talk about arthritis, we simply mean the breakdown or wearing of that protective layer. It's somewhat analogous to a car tire. And so the question is, why do some car tires wear faster than others? Well, it may be that cartilage or that tire is bad quality. It may have had a defect. It's more likely to wear sooner. It may be due to the driving habits of that particular person. It may be due to something like a freeway where heavier loads or more frequent wear occurs. That's going to break down sooner. Well, similarly, in the human body, the joint can also suffer from that. And so rather than having that smooth protective layering, it becomes worn and the bone exposed beneath, which causes pain. Typically, people who have hip arthritis or hip pain will have pain in the groin because that's where the hip joint lives. It can be on the side of the hip. It can even radiate down to the knee. It's typically with weight bearing. It can occur with prolonged sitting or when rising from a chair. And because the cartilage is gone, that surface is no longer smooth, often stiffness sets in, and typically shoes and socks can become difficult, or stairs can become difficult to do. It's important to know that many people can have referred pain. Like I said, hip pain can refer to the knee in about a third of patients. A small percentage of patients actually will present with knee pain only. So it can be somewhat deceiving when people present with leg pain. It's because the nerve that supplies the hip joint also supplies the inner knee. And so the brain will sometimes interpret that as knee pain. Cartilage, that white protective layer on the end of the bone, is invisible on X-ray. And so because there's cartilage on the end of this bone and there's cartilage on the inside of the cup, when you put those layers together, you get a gap on X-ray. A gap is good. That means there's cartilage on both sides. On X-ray, as that cartilage wears, those bones become closer and closer together. You can see it starts to wear more. You can see that the bone starts to react and get harder. It turns more white. Sometimes the head can even sublux, and sometimes, like in this patient, the head simply eroded away. So these are all different degrees of hip arthritis on X-ray. The bottom line is there's no cure for arthritis. Once that cartilage is gone, unfortunately, we cannot put it back. We can't grow it and inject it or insert it. It's like a car tire that's been blown. Unfortunately, at that point, it needs to be replaced. And so now we'll talk about what is hip replacement. Hip replacement is a resurfacing of the hip. It's recreating a new ball and socket. It's been around since the 1960s, and really one of the American godfathers was Bill Harris at Harvard, who Dr. Dearborn and I both had the privilege to work for. Hip replacement is removing that worn ball, and it's inserting a metal stem inside the bone and then attaching a metal ball to it. That metal ball serves as a new femoral head, and it articulates in a plastic liner or metal liner or some type of liner, which is fixed to a metal cup which goes into the pelvis. So both sides of the joint are recreated so that now that articulation is artificial. So there's no pain and it's smoother. Hip replacement has obviously evolved. When it was first in the 1960s, the approaches were much larger. There was more soft tissue and bony damage. Gradually with time, those techniques were refined. And so instead of having major dissections and long recoveries, things have evolved to something like this, these less invasive surgeries, which we'll talk about very soon. Actually, we'll talk about it now. So minimally invasive or less invasive hip surgery. What is it? Well, less invasive hip surgery, really the idea is to provide the same good long-term result with the artificial joint, but to do so with a shorter recovery time. With less soft tissue injury, there's reduced patient pain, there's less blood loss, there's a shortened hospital stay. We don't want to increase complication rates, but we want to restore people back to their activities faster. If you go into Google and you do a search for minimally invasive hip replacement, 405,000 things will come up. So there is a lot of information out there, and it can be difficult to understand it or to weed through it all. So hopefully I can answer some of your questions shortly about it. There are many, many approaches, like I said. This is a standard approach, and there are many different types of minimally invasive hip approaches, and we'll talk about most of them here. But based on our experience, based on our research, based on published literature, this is what we do at our institution most frequently. It's a mini posterior approach. This is a diagram of a traditional hip approach. It's in medical school anatomy books. And this is what we're doing today. So you can see it's much smaller, the abbreviated skin incision. But it's not only the skin incision that's different, it's also the muscles dissection is different. We try to abbreviate the gluteus maximus split. We try to avoid affecting the gluteus maximus tendon, and we try to avoid the quadratus femoris, all these muscles around the hip. By not affecting them during the surgery, obviously recovery is that much faster. So again, this is what a traditional hip replacement would look like, and with the hip replacements we do here, much smaller incision, much faster recovery. So a lot of it again has to do not with the length of the incision, but more what happens beneath, which is reduced trauma to the tissues below, which again, the bottom line is people recover faster, walk faster, return to their activities quicker. The advantages of this mini posterior approach is that it's a highly familiar approach. It's easy to learn. It's also extensile. If there is an unforeseen complication or an anatomical variability that was unforeseen, this approach can be extended so it can be addressed appropriately. Some of the other approaches I'll talk about are not extensile, and so less than satisfactory implant position sometimes has to be accepted. This approach also avoids major trauma to the abductor muscles and other muscles, which can lead to limping, prolonged limping after surgery. And this approach is also amenable to both cementless and cemented hip replacement techniques, which we'll touch on a little bit. In our hands, we can apply this minimally invasive approach to really all comers. It allows us to use, again, cementless devices in about 90%. That's the most common. Cemented or the hybrid technique is in osteoporotic bone, maybe softer or weaker bone, where we can cement in that component, but we can do it safely through this approach. And again, we typically use metal on highly cross-linked polyethylene as our standard bearing surface. And we use epidural anesthesia whenever possible for the patient. With these approaches, it's rapid physical therapy, rapid progression in weight bearing. Weight bear the day of surgery, actually. Most people will progress and be able to walk with a walker or a cane the day after surgery, and about over 90% of our patients are able to be discharged the day after hip replacement. So looking at the recent surgeries, again, our average length of stay is just over 1 day for all comers for hip replacement. About 90% discharge using a cane or no assist device, but again, 95% go home, not to rehab. When we were in training, people with hip replacement were in the hospital bed for 4 to 5 days. They were on a walker for 6 weeks. All that has changed with these new techniques. So really what we expect is people are going to transition to a cane or nothing at all within that first week. Hopefully they'll be rid of that cane by 2 weeks, driving around the 2-week mark. We let people start golfing at 6 weeks, and we expect people to feel completely recovered near 3 months. We like people to say that it feels like a normal hip, and most people can say that. As an example, this is an 85-year-old patient who every year would go with his friends to Mexico to play cards and boogie board, and 3 months after his hip surgery, he sent me this picture. He didn't miss his annual meeting. So this is just a brief video of a random patient, just to give you an idea of what the typical hip replacement patient will look like. This is his x-ray where he has bone-on-bone arthritis. He's lacking that space between the ball and socket, and so this is him in the pre-op holding area, and we just asked him to take a walk to see how he was doing right before surgery. He required a cane. You can see he's limping on that leg. He was very limited. He had to give up golfing. He couldn't go on his normal evening walks, and he was in significant amount of pain, requiring pain medications. So we did the hip replacement. This is what it looks like on x-ray with the metal stem, the metal ball, and the cup. And so we have our patients walk hours after surgery. So his surgery was later in the afternoon. This was in the early evening, a few hours afterwards, and we have him walking with a walker, and the therapist, you can't hear it, but she's asking him how his pain is. He says it's 1 to 2 out of 10. He's also saying that that knee pain he had before is completely gone. So the next morning after surgery, we have him walk again, and now he's progressed to his cane, back to his cane. We have him walk stairs, make sure he's safe so that he can go home and take care of himself. And this is, 16 hours after surgery. It's just the next day after surgery, and he says, I'm ready to go home. And for his first post-operative appointment, this is about 12 days after surgery. He's walking in clinic, and you can see compared to how he was walking right before surgery, he's already walking better. So this is our average patient. This isn't something special. This is what we anticipate most of our patients will be able to do. Now that is our approach, the mini posterior approach, and that's what we do. There are many other approaches, and I'm going to talk about a couple because maybe you've heard about them in advertisements on television or in magazines. There are approaches from the front of the hip, the anterior hip. There's ones from the side, the lateral. Again, the posterior we already discussed. The bottom line is there are many different ways to get to the hip joint, and that's what all these different approaches describe. So this is one which it's basically a lateral approach. And historically, there were some good things about it in that you could do it without an assistant, and there may be better hip stability historically. But the problem was people would limp for a prolonged period of time, and research has shown that it could damage some nerves in the nearby area. But probably the approach most of you have heard about, or maybe there's been a lot of buzz lately, is this anterior hip approach and this hip surgery done with this special table. Well, there's nothing really special about this table. It's just that you have to have this table to do this approach. You have to be able to pull on the leg, so the leg's in this boot, and you have to have this special retractor to lift the femur up to expose the hip through the front. So this is the anterior hip approach. Problem with this table and this approach is now that you're pulling traction on the leg, there have been people who have had ankle fractures. There have been people who have had fractures of other bones because you're pulling so hard. So it's definitely technique driven. There are risks. And there's been various literature publications showing that there are, again, risks to nerves. There may be not fast recovery as some people promote, and that there's really maybe no benefit, even though some surgeons claim that there will be. So you have to be cautious with what you believe. As an example, some of you may have seen this ad which was in the paper. This is the group in El Camino who takes an ad talking about their anterior hip approach. And they tell you about all the benefits and other things. Well, somehow Stanford got their data, and Stanford published this article in one of the orthopedic national journals. And what they found was that this group had 165 average OR time. So it took nearly 3 hours to do a hip surgery as opposed to the 1 hour it takes here. They had 2 times the blood loss. So people had higher chance of needing blood transfusions and other things after this surgery. But also, the complication rate was 9%. Our complication rate, we hope, is less than 1%. So it's over 9 times higher than what we expect here. So while it looks good in advertisement, you have to be aware that there are real complications with some of these other approaches. So why doesn't everyone do minimally invasive hip surgery? Well, really, it's because it's technically difficult. We're using the same implants, the same metal components on both sides, but we're putting it through a smaller window, so to speak. JVJS is one of the most respected orthopedic journals, and these are 2 landmark articles looking at the association of surgical volume by a surgeon in a hospital with outcomes with hip and knee replacement. What's interesting with these articles is that they showed an amazing statistic that the majority of joint replacements in the country are put in by surgeons who do fewer than 10 per year. So that means they don't even do 1 a month. But there are many surgeons out there, and they're putting in most of the joint replacements. These articles also showed that higher volume surgeons and higher volume hospitals typically have better outcomes, as you would expect, and lower complication rates. The cutoff was about 200 procedures. We do probably over 1,300 joint replacements a year. So it's important to match that threshold in order to maximize the outcome. So when you select your hospital or surgeon, it's important to keep that in mind. Again, it's technically difficult. This is a hip replacement. This is a traditional hip replacement. And there's nothing wrong with that, but if we can do the same thing through a smaller incision and speed recovery, we would like to do that. But again, this is really left best in the hands of specialists. And how do you decide how people are doing? Well, either asking your surgeon or, like Dr. Dearborn mentioned earlier, look at the objective data, look at the consumer reports, look at health grades, look at the various accolades that this institution has received for its good outcomes. So again, do research if looking into hip surgery or really any surgery. Remember that higher volume is generally associated with better outcomes and fewer complications, and then have a discussion with your surgeon about what may be best in your particular case. Next, I'm going to talk a little bit about joint bearing surfaces. This has been in the news a little bit as well. This is metal on metal articulations. The idea behind it was that there may be less wear. You know, we worry about the wear rates of these artificial joints. And in the laboratory and in theory, this articulation seemed to have good properties. Unfortunately, when it was put into people, it was put into younger people because that's where we really wanted the wear to be better. We did not do that here because we had concerns about it, and in the New York Times and others, these young people were having failures. And so now these young people, where you were trying to avoid revision surgery, were needing revision surgery after just a handful of years. This is Josh Jacobs, who I work with in Chicago, and he's really one of the metal experts in the country. And this article came out after Johnson & Johnson recalled 93,000 of their metal-on-metal hip replacements. Happened a couple years ago, and you may have heard about that. But that bearing does have its concerns, and so really it's fallen out of favor lately. Another bearing is ceramic on ceramic. Same idea. Hopefully it will have less wear. The problem is that ceramic is very brittle, and ceramic can fracture. And if this ball fractures in the hip joint, it's very hard to clean up all these little pieces and put in another hip replacement. It can lead to other problems. But with any new technology, there's also the possibility of introducing a new complication. In this case, there have been instances of squeaking with this bearing. So this person with a ceramic on ceramic hip, right? When that person walks, they sound like a squeaky door. And while they may not have pain, you can imagine that could be quite annoying. Not going to sneak up on anybody. This is another person. So quite dramatic. And you can see the New York Times, again, wrote a big article about this problem with the squeaking hip. So what we do here is what's tried and true. Metal on plastic. It's been around for decades. We know it works. We know what it does. And we really have to be cautious with new bearings until we know they're as good of standard bearings. Lastly, I'm going to talk a little bit about our research here. Because of our volume, because of our database, because of the protocols that we do, we're able to generate a huge amount of research, and we present it yearly at the national meeting, our orthopedic associations, the American Academy of Orthopedic Surgeons. We do that each year. We also publish it in manuscripts, and we present our data with posters and presentations. This is just an example of some of the research we've done recently. This was in San Francisco, looking at knee replacements, people who have double knee replacements, and how one size can actually differ from the other. Not unlike some of you may have one shoe size that's different than the other. Same thing with knee replacement, and it's important to know how that can affect surgery. This was another presentation we gave at the Western Orthopedic meeting about cemented hip replacement, which I talked about earlier, and the good results you can have with it. Talked a little bit about in Chicago at the last AOS meeting about the female knee and the results with the gender-specific total knee. And upcoming this year, we're presenting again at the American Academy of Orthopedic Surgeons and the Orthopedic Today meeting. We're talking about implant size and patient outcome differences in staged bilateral hip replacements. So not unlike the knee, the hips can also vary in size from one to the other, and that can affect surgical decision making. Also looking at some of the early results with a proximally coated tapered femoral component, a specific design and its good outcomes. And also we're presenting data looking at the use of cemented versus cementless implants in patients aged 75 or older, looking at the risk to benefit of using a cementless device, which could risk fracture, versus using cement where there may be less bleeding because of it and less fracture risk. So with that, I appreciate your time and attention.